Do you have, one, are there kind of profession-wide standards? And two, do you have personal standards that would lead you down the road of saying, okay, this individual is ready for this procedure? And I'm going to make it simple and say, let's not talk about the people that have had specific trauma, car accident, falls, things like that. Let's talk about the individual that presents to the office with, persistent knee pain, obviously degenerative changes going on. What are some of the criteria that you as a surgeon would be looking at to say, okay, this is a potential candidate?
Sure, yeah, and certainly this is a conversation I have with patients on a daily basis. So, number one, it's how much is the pain stopping you from doing what you're doing? So, if you're having occasional knee pain and I hate to give the number category
Sure.
of what your pain rates, so I would say, but if you're just having occasional knee pain that doesn't get to a point where, yes, it's annoying, but it's not necessarily stopping you from doing things, then I think you're still, and you may already still be in a category where we're looking at non-operative options. I mean, we have several things, short of just using anti-inflammatory medications, doing therapy, strengthening the knee, wearing braces. Oftentimes, I'm performing lots of injections in the office with either cortisone or joint fluid or gel, as it's commonly called. There are, some other hot topics that are not covered by insurances called platelet-rich plasma, and this idea of quote unquote stem cells, which may or may not be stem cells if you look at some of the science. But at the end of the day, the problem is that we have really nothing in our medical armamentarium that stops arthritis in its tracks or reverses it.
Right.
And as I say to patients, as you add candles to the birthday cake, this will always get worse. It's a matter of how much it's limiting you in your daily life. A lot of patients come in not really fully realizing how much they've already given up. You
Right.
have conversations of, well, do you still play golf? Do you still go for a walk? If you wanted to go for a hike tomorrow, would you do that? Does your knee keep you from doing things just simply because you don't want to deal with the pain afterwards? So, first we start by treating the symptoms. Certainly, the X-rays and the, show us that yes, arthritis is why we're having this conversation. And one of the correlations that we've never really made in medicine is how bad the X-ray work looks versus the pain that the patient has. So,
Correct.
there's some people with some pretty mild arthritic changes. So you have a younger patient, maybe in their late 40s, with mild looking arthritic changes on an X-ray that is starting to have, limitations to their life. Then we start looking at medically, what else is going on with them? Are they overweight? Do they have diabetes? Do they have other risk factors that make surgery a little bit more risky? And if they do, we need to really start modifying those first, because helping them be as healthy as possible when it's time to undergo surgery is the goal. Now,
Right.
I say I still replace skinny people's knees too, so it's not always a matter of weight,
Right.
but it's a team sport in my world. Joint replacement, it's a two person deal here. The patient has to want to have do some things that can improve their outcome, and I want to give them the best joint replacement possible. So you put those two things together, and you more often end up with a very successful outcome, and you're both very happy. So a lot of that stuff in a younger patient is how bad is the degeneration? Can it wait? And if it can wait, then let's look at some of these alternative strategies for pain relief, and try to optimize what they can get out of the knee they still have.
Sure.
As I say, trying to keep the original equipment working, as long
Right.
as possible.